I have no disclosures. So endometrial cancer is the most common gynecologic malignancy that affects women. It's the sixth most common cancer in women overall. And women actually have a 2.5% lifetime risk of developing cancer. There are around 400,000 cases worldwide and approximately 62,000 in the US. The typical patient that develops endometrial cancer is in her 50s or 60s, so she's older, but about 5 to 6 to 7%, depending on which study or statistics you look at, show that it does affect women of reproductive age.
Yeah, you should be able to. No? Okay.
So there are different types of endometrial cancer. I'm not going to go over all the pathology in detail, but it's important to understand that the most common type of endometrial cancer is adenocarcinoma. And of the adenocarcinoma classification, endometrioid is the most common subtype. It's important to understand this because this is the type of endometrial cancer that actually responds to hormones. So we can treat and possibly cause regression of this type of endometrial cancer. The other types of uterine cancer that are listed, unfortunately, do not respond to hormonal treatment and are much more aggressive. Okay, am I pushing the right? So there are also grades of endometrial cancer. There's grade 1, and with grade 1, 95% or more of the cells represent glandular tissue, like endometrial glandular tissue. As the grades increase, the amount of glandular and normal appearing tissue decreases. So with grade 2, 50 to 94% of the cancer tissue is forming glands, and with grade 3, less than that. So with grade 2 and grade 3, those are less differentiated types of cancers, and they're going to be more aggressive and less hormonally responsive. I'm also going to talk briefly about endometrial cancer precursors, such as the traditional term complex atypical hyperplasia, which has now been replaced by endometrial intraepithelial neoplasia, because many of the studies that are looking at early stage endometrial cancer are also treating women who have endometrial hyperplasia with atypia, because that type of hyperplasia, which usually has around a 20 to 25% chance of progressing into endometrial cancer, is also hormonally responsive. Risk factors for endometrial cancer, the biggest risk is increasing age, but for younger women, risks of endometrial cancer include obesity, polycystic ovarian syndrome, and nulliparity, and also diabetes, which goes hand in hand with PCOS. Obesity, as we know, or most of us know, is actually a large risk factor for endometrial cancer. And you can see for type 1 endometrial cancer, which is the type that we can treat hormonally, the level of obesity increases the patient's risk of developing endometrial cancer. So for someone who's just simply overweight with a BMI of 25 to 30, the odds ratio is around 1.5. But you can see it increases for someone with a BMI greater than 40. The odds ratio of developing endometrial cancer is 7 or 7.1. So with this patient population with obesity comes an increased risk of developing endometrial cancer. So when they come to us for fertility preservation consultation, oftentimes they have BMIs of 40 or above, which complicates the whole process. So the standard approach to treating endometrial cancer, the standard of care, is a total hysterectomy with removal of the fallopian tubes and the ovaries. That is the standard of care. It also includes pelvic and periaortic lymph node dissection or assessment. So that's the standard of care. Now, unfortunately, if you're a young woman who's nulliparous with newly diagnosed endometrial cancer, that is not good news. That's why the practice has started of treating patients hormonally. So obviously it would be very devastating as a young woman who would like to have a biological children to hear that the treatment recommended is hysterectomy with removal of the ovaries, especially when they're thinking of fertility. So the fertility-sparing alternative would be progestin therapy and deferral of surgical staging until childbearing is completed. In most cases, this would be allowing the patient to get pregnant and have one child. Candidates for a patient that we can treat what we call conservatively or hormonally includes a patient who has histologically confirmed endometrioid type endometrial adenocarcinoma. So it has to be type 1. It has to be a very well differentiated tumor. So at our institution, we review the pathology at tumor board, and the oncology team as a group decides whether that patient's a candidate for conservative treatment or not. The disease must be confirmed to the endometrium. Obviously, that's challenging since we're not assessing the uterus surgically or pathologically. So MRI is the most common way that GYN oncologists will evaluate for myometrial invasion. The patient must have a strong desire to preserve fertility. She'd already completed her childbearing goals, and hysterectomy would be fine. Age less than 40, ideally, just because that patient's going to have a better chance of success or conceiving by the time her endometrial cancer regresses. That being said, I will often see patients who are older, at least for consultation. There can be no contraindication to progestin treatment. And the patient must understand and be counseled extensively that this is not the standard treatment and there are risks involved. So understanding the risks is very important. That counseling will take place primarily by GYN oncology, but when you see the patient as well for consultation, I think it's important to counsel the patient and document in the chart that even although this is clinically a stage 1 disease, we're not completely staging her. So there is the chance that she could have tumor outside of the uterus. One study showed that the risk of an undetected tumor or cancer cells on an ovary is high as 25%. Other studies have shown that that's it's lower, like 5%, but regardless, there's still this risk. Also, it's important to tell the patient that just because we've helped with regression of your endometrial cancer, you may still have trouble conceiving after treatment. So as far as the treatment options, there really aren't any standard treatment options. There's not one recommended treatment that's better than the others. When I first started seeing patients with endometrial cancer, oral progestins with either medroxyprogesterone or megestrol acetate or Megase. Megase was the most popular, and varying doses, depending on who the GYN oncologist was, were the most common. In recent years, I see that GYN oncologists are recommending more and more the Levonorgestrel IUD, which is very convenient and nice since we can proceed with IVF and keep the IUD in place. As far as surveillance goes, the patient requires endometrial sampling and/or hysteroscopy every 3 months. Typically, once a patient regresses, we'll do an endometrial biopsy in the office every 3 months as she's going through treatment. So as far as the response to oral progestins, there's been several studies done. They're all smaller studies, some are retrospective. So most of the data that we have are from meta-analyses. So there's a couple of meta-analyses. This was actually done by one of my residents at Hopkins, a meta-analysis of 45 studies, 280 patients who had grade 1 endometrial cancer that was treated with progestins. The complete response rate or regression of the endometrial cancer was about 48%. The average time of response was 6 months, and the pregnancy rate was around 35%. One other study was another meta-analysis of 34 studies that included 408 patients that had presumed stage 1 endometrial cancer, managed once again with oral progestins of varying doses. In this study, the regression rate was 76%, but the recurrence rate after regression was 41%. So that's why it's really important to counsel these patients. Yes, you are in remission, it's regressed, but we need to move quickly to help you conceive. Following treatment, once patients had their definitive surgery, about 1.8% of patients had stage 2 or higher endometrial cancer. So that's good news. The live birth rate after treatment was around 28%. Now, one thing that I've seen with the oral progestins very profoundly is weight gain. And so this can be challenging, especially if you have a BMI limit for IVF at your center of, say, 45, which is what our current BMI limit is. It used to be 50. Because I've seen patients gain a lot of weight with the oral progestins, it actually can be used to help patients gain weight who have other issues. So this was just a study that was done at Hopkins where we were looking at our patients to see how much weight they were gaining when we were doing the conservative treatment. So we had 60 patients with endometrial cancer with a average BMI of around 40, which is pretty average for our patients. The median weight change during therapy with Magee, which is at the time what our GYN oncologists preferred to prescribe, which is an oral progestin, and was significantly greater than using the IUD. So over the 6-month period, the average patient on Magee gained around 3 kilograms. The good news is as we started moving toward using the progestin-releasing IUD or the levonorgestrel IUD is that we don't have the weight gain issues, and there's some studies that have shown good regression of disease. There aren't any studies that are comparing directly the IUD to the oral progestin. In this smaller study, 46 women who actually had, it was a combination of atypical endometrial hyperplasia as well as early grade endometrial cancer were treated with the progestin releasing IUD. And the overall response rate at 6 months was 75%. That response rate was higher with the patients who had atypical hyperplasia, but it was still pretty respectable at 67% for grade 1 and 75% for grade 2. So it's reassuring. I think one of the other benefits of the IUD is that there's going to be more compliance with the patient because you know the IUD is in place versus someone taking medication twice a day. Let me see. Oh, did I just? So there are some studies that are looking at hysteroscopic resection, especially the standard of care when you're diagnosing a patient with endometrial cancer is often to do a targeted biopsy or do a hysteroscopy combined with DNC would be to hysteroscopically resect what appears to be endometrial cancer prior to progestin treatment. And there are some studies that show promising results as far as high regression rates. I think further studies are done to determine its safety and efficacy. One concern I would have would be how that could damage the endometrium and lead to intrauterine synechiae and decreased uterine receptivity when the patient does try to conceive. For progestin plus metformin treatment, so many people have hypothesized that there are some benefits of metformin, especially since a lot of the patients with endometrial cancer also have a history of PCOS. And there's other studies that show that metformin can be beneficial for patients with endometrial cancer. So there have been some studies that have actually used metformin as an adjunct to progestin therapy. There's been 6 studies so far with 621 women. In this meta-analysis, they looked at 241 patients that had a combined treatment of oral progestin with metformin compared to those who had a progestin alone. They did find that the relapse rates for the progestin and metformin combination were lower than with progestin alone, but the remission rates or the remission rates of the endometrial cancer were not different. Women who received the progestin and metformin combination achieved pregnancy and live birth rates that were similar to those that were on progestin alone. So the next question is, where does the fertility consultation and treatment fit into this? At our institution, these patients are referred immediately to our Center for Fertility Preservation Consultation, even though we know they're not going to be trying to conceive for probably 6 to 8 months at a minimum. But it's really important to see this patient ahead of time to do as much of a fertility evaluation as you can, because if this patient has diminished ovarian reserve or some other issue that would make it very difficult for her to conceive, then conservative treatment would not be the best choice for her. When regression is achieved, the patient should follow up with the reproductive endocrinologist as soon as possible to develop a plan. And my preference is that the plan is already developed if there's insurance authorization, because I live in a mandated state that insurance authorization is already set up so she can go straight into treatment. And it's also important to have very regular communication between the GYN oncologist and the reproductive endocrinologist. So I communicate regularly with our GYN oncologist. Sometimes if it's more convenient, I'll actually do the endometrial sampling for the patient just to make sure it gets completed. So looking at pregnancy in and of itself, I think the pregnancy rates are actually pretty impressive. And I think that they can get better, but I think that for the select patient, it can be beneficial to do conservative treatment. So this is a meta-analysis of 46 studies that included 860 women, all who had early stage endometrial cancer. So this was actually both grade 1 and grade 2 endometrial cancer. The majority of patients received a progestin-based treatment. Complete response to treatment was achieved in nearly 80% of patients, with 35% receiving a recurrence during follow-up. The live birth rate among those who tried to conceive was 69.4%. It's important to note that nearly 67% of those patients that conceived did do so through fertility treatment. So I think it would be a disservice just to send the patient away to try to conceive on her own. There really needs to be a plan to be aggressive to help her conceive once her endometrial cancer regresses. So this is interesting. This was a survey that was done of both GYN oncologists and reproductive endocrinologists. It was actually done by a reproductive endocrinologist who did a residency at Hopkins and a GYN oncologist who also did his residence with me. So all GYN oncologists, so it was a survey of over 200 of these physicians, and all of the GYN oncologists who responded to the survey said they do offer progestin treatment to patients with grade 1 endometrial cancer, and 40% would actually also offer it to grade 2. But at that time, and this was about a couple of years ago, they did the survey, the preferred type of progestin treatment was actually the progesterone IUD. 60% of GYN oncologists and 70% of reproductive endocrinologists would recommend a hysterectomy if the patient did not respond to the progestin treatment after 12 months. Most reproductive endocrinologists, or 72%, would counsel the patients who were in cancer regression or remission that they should begin ART within 0 to 3 months. So some of them said right away, some of them said fine, I'll wait 3 months, but the majority recommended moving straight into ART. There's been some concern that perhaps doing IVF could be harmful to patients with a history of endometrial cancer because it will increase serum estradiol levels. This was a study that was looking at the risk of recurrence in patients who underwent IVF versus those who didn't, and found that there was no difference in cancer recurrence rate. At our institution, we'll use the letrozole protocol for the controlled ovarian hyperstimulation to keep the serum estradiol levels low. And most of them have a have a progestin IUD in place at the time too. So this is a study that one of my fellows did. We were finding at our institution that a lot of our patients were developing intrauterine synechiae. So at the time when they were coming back to try to conceive, a lot of them had decreased endometrial receptivity and had uterine synechiae. Now this kind of goes back to the time when patients were taking a lot of oral Magee and not using the IUD, and also patients were having D&Cs every three to 6 months. So we actually did a retrospective analysis of our fertility preservation database and looked at the patients over around a 15-year period that were conservatively treated for endometrial cancer that underwent hysteroscopy where intrauterine synechiae could have been identified. So looking at that patient group, we had 54 patients. The mean age was 34. The mean BMI was 34.5. 85% were nulliparous. And it was a combination. Some of them actually did have endometrial hyperplasia with atypia. The progestin treatment, you can see that over half received Magee, oral progestin, which we don't use as much anymore. The ones that used IUD alone was only around 13%, and about 30% were using a combination of an oral progestin and the IUD. What we found was the average patient had received about 4 D&Cs over that 12-month period. We're not doing as many D&Cs today. We're doing more endometrial biopsies, but so that a lot of them were getting more D&Cs than normal. And when we evaluated the uterine cavity, what we found was the rate of intrauterine synechiae was around 19%, so it was quite high. Just a little bit about our pregnancy rates. And so overall, about 41% of our patients went on to attempt pregnancy for various reasons. Others decided not to. Of those patients, we had 20 pregnancies, 5 were spontaneous. 1 was through kind of ovulation, induction, and timed intercourse. 6 proceeded with IVF. Overall, 41% of the patients had greater than 1 live birth, but the live birth rate was around 65%. Okay, I'm almost done. So the strategy for conservative treatment of endometrial cancer is the patient should be told that this is a strategy to delay definitive surgery until after pregnancy, and once regression occurs, pregnancy should be achieved within the shortest amount of time, and that ART is perfectly reasonable. So this is kind of the recommendations that we have thus far, that we're using a multidisciplinary approach. The patient must be counseled. This is not standard of care. A fertility evaluation should be done very early. And once remission is achieved, fast track to IVF, and that close communication is needed between the GYN oncologist and the reproductive endocrinologist. And that is the end of my talk. Thank you for your attention.